Good morning, everyone. My topic today is going to be on spondylolisthesis. Okay, here's a bit of an outline on what I'm going to talk about today. First of all, because we've got some medical students here, I'll go over very brief anatomy of the spine. Spine consists of the cervical, thoracic, lumbar, and sacral region. And as indicated here, there's 7 cervical vertebrae, 12 lumbar, 12 thoracic, 5 lumbar, and the sacrum. In terms of the curvatures of the spine, the primary curvatures when an infant, the spines are kyphotic, which remains in the thoracic spine and the sacrum. But then we get a secondary curvature of the spine in the cervical and the lumbar, which becomes lordotic. In the cervical, that starts off first by about 6 months when the infant starts lifting the head up, and by about 1 year of age, we get a lumbar lordosis, which allows us to stand upright. And here, some more anatomy of the spine. Here's the vertebral body. We have here the pedicles, the lamina on each side, spinous process, transverse process, and we've got the superior and inferior articulating facets. Intervertebral disc in between the bony vertebrae, and also looking at the facet joints, the alignment of the facet joints changes according to the in the cervical spine they're oblique, the thoracic they're orientated in the coronal plane, and in the lumbar spine they're orientated in the sagittal plane, as indicated here. And again here we can see some segments from the thoracic spine where the facets are orientated in this plane here. And again, ligaments of the spine, anterior longitudinal, posterior longitudinal, the ligamentum flavum, interspinous, and the supraspinous ligament as well. At each level, there's an intervertebral foramen where the spinal nerves emerge. In terms of my discussion this morning, the pars interarticularis, or known simply as pars, also known as the isthmus, is the area here, which is between the inferior and the superior articulating facets, and which is also anterior to the lamina and posterior to the pedicle. Isthmus is also known as a narrow passage which connects two larger bodies, and that's why they use the term here, I guess, in terms of everyday. This is the Corinth Canal in Greece, we call Isthmos Corinthou, which connects, it's a narrow passage of water which connects two large areas of water. I thought I'd put that up because I'll be there next week. And that's actually a motorbike there, jumping across. Some definitions. So spondylolisthesis comes from the Greek word spondylo, which means spine or vertebra, and lissi, which means loosening. So putting the two words together, loosening of the spine. It's a defect in the pars interarticularis, as I showed before, and that can be without displacement of the vertebral body. So spondylolisthesis is the presence of the defect without any movement of the vertebral bodies on each other. And here I've got a 3D image with a defect there demonstrated, and again on a plain X-ray on the lateral view you can see where the circle is there's a shadow there, which is a defect in the pars. And again here, we've seen that X-ray on the axial CT scan. You can see the defect at the pars, and there's sclerotic margins on this slice. Spondylolisthesis. Again, spondylo for vertebra, and listhesis is from the word olistos, which means slippery or slipperiness. So, in other words, the slipperiness of the vertebral bodies. So, spondylolisthesis is essentially the forward translation of one vertebral body on the one below. It could also be translated posteriorly, but most commonly forward. And this could be in the presence with or without spondylolisthesis, so hence a pars defect. And I'll go into that in a second. So spondylolisthesis and spondylolisthesis, they're common causes of low back pain in children, in adolescents, and also in adults. The upright posture of humans and the way we ambulate can be contributing factors. Spondylolisthesis rarely occurs in infants because they don't walk. At the age of around 6 years, incidence is approximately 5%, which is similar to the adult population. Most children are asymptomatic. It's said that there are hereditary factors involved, and sporting activities can exacerbate this, or high stress sporting activities. For example, gymnasts have a high incidence of this, and people that do springboard diving. So repetitive hyperextension and rotational loads to the lumbar spine, and the incidence in elite athletes can be up to 47%. Spondylolisthesis most commonly occurs at L5. It may occur further up in the lumbar spine, but most commonly in L5. And spondylolisthesis, that's most common at L5, S1 in children and adolescents. Now, in terms of the classification of spondylolisthesis, we can look at it in terms of the etiology or the type, and also the severity or the grade. Now, in terms of the etiology, it's the Wills-Newman-McNabb classification from 1976, and they classified it into 5 types. Type 1 is the dysplastic type, or congenital. Type 2, isthmic. Degenerative, type 3. Type 4, traumatic, and type 5, pathologic. And I'll go more into that now. So in type 1, or the dysplastic, the incidence is around 20% of spondylolisthesis is due to dysplastic. Occurs in children. So a few ways this can happen. You can get congenital dysplasia of S1 superior facet, where it can be mal-orientated or hypoplastic, with some sacral deficiency as well. Or the pars can be poorly developed. It can be there can be elongation of it with the ventral separation. And with the dysplastic type, there's a slow forwards slip of L5 on S1, and that can lead to very severe displacement. Now, type 2, the isthmic type, as I said before, it's a defect in the pars interarticularis. This is the most common. It's around 50% of the cases of spondylolisthesis. It can occur from childhood, from the ages of 5 to around 50 years. most commonly occurs in L5-S1. The defect can be found in 5% of people, but asymptomatic. But you can have a defect initially and then slip later on in life. A family history may be present. And then spines, as I've said, spines that have extraordinary stresses that are going through it. So gymnasts, weightlifters, people that do springboard diving can have a type 2 spondylolisthesis. So type 2 is divided into 2A and 2B. In 2A, you can get disruption of the pars as a result of a stress fracture, hence spondylolisthesis. And that's from repetitive loading. Here you have a complete radiolucent defect, which you can see on plain films. And this is the most common subtype. Type 2B, you get elongation of the pars, which is secondary to repetitive microfractures and healing. So you get microfracture healing, and that continues, and that eventually elongates the pars interarticularis. This can be difficult to distinguish between the dysplastic type. And 2C, where you get an acute fracture through the pars. And I've got some illustrations here. 2A, where you have a defect there. 2B, where it's elongated. And 2C with an acute fracture. Type 3, degenerative, occurs in around 25% in older adults. And that could be secondary to degenerate facet joints. And that can lead to instability and then hence the listhesis or the forward slipping. In type 4, which is a traumatic type, obviously that can occur in any age, and that's an acute fracture other than the pars. And type 5 is a pathological, again, any age, where bone destruction is present, and you end up with incompetence of the bony elements. And here some illustrations: type 3, 4 with the fractured pedicles, and then 5 with the tumour. In terms of severity or the grade, the myodine classification, grades 1 to 5, depending on the degree of slippage. In grade 1, it's up to 25% of anterior slippage. So that's normal here, that's grade 1. Grade 2, between 25 and 50%. Grade 3, 50 to 75%. And grade 4, more than 75%. Grade 5 is when there's 100%, which is known as spondyloptosis. So the whole vertebral body has moved forward compared to the one underneath it. We can look at some measurements as well. So the slip angle, which is demonstrated here, which looks at the degree of lumbosacral kyphosis. So a line taken here on top of the sacrum, and another line on top of L5, and this is the angle in here. So the bigger this angle, the bigger the slip angle, so the more kyphosis is present. So more than 50 degrees, there's a significant increased risk of progression to progression of the listhesis, hence the forward slippage. In terms of the natural history, in type 1, the dysplastic type, the L5, because it's dysplastic and there's no defect in the pars, the posterior elements are intact, as we can see here. So there's no defect in the pars. Now, when you have forward slippage of one vertebral body on the other, it'll bring along the posterior elements as well, hence can cause compression to the exiting nerve roots. And you can end up with a radiculopathy. You can also have bowel or bladder dysfunction from the sacral nerve roots. So children and adolescents with type 1, they're more likely to develop a neurological injury or neurological symptoms. So they have an increased risk of progressive deformity, and also compared to type 2, which is around 4%. And they're more likely to require surgical intervention because of that, because of the neurological symptoms that they might have. In type 2, the isthmic type, as I said, common in athletes with high-risk sports, where there's repetitive loading of the lumbar spine in extension and rotation. You get stress reactions in the pars, the lamina and the pedicle. It can be unilateral or bilateral, so both of the pars on each side can be affected. The unilateral ones almost never slip, and L5 is most common. With immobilization, the stress injury may heal. If untreated, you may end up with a well-defined lucid defect. In terms of the presentation or clinical features, a lot of times it's an incidental finding on plain films. In children and adolescents, it can be asymptomatic. However, children may present with low back pain. It could be intermittent, so related to exercise or strain. Occasionally, they may have pain in the buttocks or the posterior thigh, and they may have a gradual onset in terms of the symptoms. They may have radicular symptoms and disturbance of bowel or bladder function. With low-grade spondylolisthesis, they really do have neurological symptoms. However, with a high-grade slippage, they may have these symptoms. In terms of the gait, with the advanced degree, so type 3, type 4, they might have a short stride. As indicated in this picture here, they usually are flexed at their knees and at their hips, and that's secondary to hamstring tightening. They may have a flattened lumbar lordosis, which is common, and the sacrum it also appears vertically orientated, and I've got a picture of that next. Also, when looking at the knee, the popliteal angle, they have some degree of flexion in the knee joint, which is due to the hamstring tightening. They may have a palpable or visible step when you look at the lumbar spine. They may be stiff, so flexion and extension may be limited, and they may have pain when you hyperextend their lumbar spine. In terms of you obviously need to do a neurological examination. You may need to do a PR exam if you're suspicious of any bowel or bladder dysfunction, and a straight leg raise may be positive due to nerve root irritation. In adults, back pain is common in adults. It may or may not be related to spondylolisthesis. And again, they may have radicular pain with a dermatomal pattern. If there's an impingement of an exiting nerve root, could be again, due to the spondylolisthesis or to any associated degenerative factors related to the spine. In the ismic type, the L5 nerve root impingement, they can have that, and complete occlusion of the quadraquina is rare compared to the type 1, the dysplastic type. Here, the vertebral body and the posterior elements are dissociated from each other, so when you have forward slippage of the vertebral body, the posterior elements don't really move with it. In terms of investigations, start off with plain films. So a standing PA X-ray and lateral of the thoracolumbar spine. In the PA view, you may find coexisting scoliosis. In the lateral, you can identify the spondylolisthesis and the degree of the listhesis or the slippage. In the supine oblique views of the lumbosacral spine, may help with diagnosing any stress reactions and spondylolytic defects. SPECT or single photon emission CT of a lumbosacral spine, that's most effective for detecting spondylolisthesis if the X-rays look normal. So if we have a suspicion of this, this is a useful investigation. So if there's a stress reaction, usually there's increased uptake in the pars, in the pedicle or the lamina. With serial SPECT scans, with decreasing uptake, usually occurs when the condition's improving, and usually it's correlates clinically as well. Fine slice CT is useful for defining the bony anatomy, also the degree of the cortical disruption, the lysis and any sclerosis as well. Serial CT scans also will demonstrate the progressive healing of the stress reactions. MRI is also useful if there's any neurological signs or symptoms. In terms of management, there's always the non-operative and operative. I'll start with non-operative. For stress reactions, they do have the potential to heal. That can be unilateral or bilateral involvement of the pars. The healing potential is greater if it's unilateral. So with prompt diagnosis and management, the outcome will be improved. Brace immobilization is used for 6 to 12 weeks. The brace can be taken off if the patients are pain-free in lumbar extension and rotation, and there's evidence of progressive healing on the CT scan. After the brace comes off, you can start physiotherapy gradually. Fibrous non-union can occur, but this can be stable, and the patients can go on to full activity even with this. With spondylolisthesis, the goal is mainly to alleviate the pain and improve patients' spinal mobility. The goal isn't really to achieve any bony healing. We need to search for any other causes of the pain, because, as I've said before, most cases of spondylolisthesis are asymptomatic. Period of restricted activity in physiotherapy, with then return to full activity. The brace isn't often needed in spondylolisthesis. With low-grade spondylolisthesis, again, non-operative management would be to restrict activity with then physiotherapy and maybe a brace as well. And again, the aim to full activity when pain resolves and there's more spinal mobility and this hamstring tightness has resolved or improved. With low-grade ischemic, again, that really progresses. However, low-grade dysplastic can progress, and with the increase in slippage, with the development of neurological symptoms, they may require surgery. So, operative management for spondylolisthesis and low-grade spondylolisthesis. If there's persistent pain or neurologic dysfunction, operative management may be indicated. If we've tried non-operative management for 6 to 12 months and that's failed, then we might consider operative. L5 to S1 posterolateral fusion with an L5 ischemic defect in children and adolescents. We can also repair the pars defect, which is usually at a level of L1 to L4. With high-grade spondylolisthesis, management here can be controversial. Not everyone with high-grade spondylolisthesis needs surgery. Some patients can be managed non-operatively. There's a few different ways we can operatively manage these patients. In situ fusion, I believe, is a preferred method. Here they do a laminectomy and decompression, and then they drill a tunnel from S1 to L5, and they insert a bone strut into there, and then fuse posterolaterally with bone graft from L4 to S1. You can have fusion with reduction. There's many techniques described. I'm not going to attempt to go into them. And also partial reduction and fusion, which where they do a decompression, a laminectomy, they do a partial reduction, and then they use instrumentation with pedicle screws, and then also posterior lateral interbody, which is a posterolateral interbody fusion. Patients in the degenerate group, decompression alone can be all that is needed with a laminectomy, or decompression with non-instrumented posterior lateral fusion, where they insert bone graft, or decompression fusion with instrumentation, which is this. And that concludes my talk.